Hey, good afternoon, everyone. Um, I'm Joyce. You know me, so I won't go into details. I'm sorry, Dr. Patzer was ill today, and she had planned to be here, but is unable to attend. So she asked me to do the introduction of our guest speaker today. So I'm happy today to introduce Manmeet Kaur. She's the Chief Population Health Officer and co-founder of Divergent Health. This is a company she co-founded in 2023. Before that, she was involved in starting an organization called City Health Works in Harlem, New York. And the mission of that organization was to help people with chronic conditions gain the knowledge, skills, and confidence to take control of their health by building a new workforce of locally hired, highly trained health workers or health coaches. City Health Works delivered industry changing results, including a 7-to-1 return on investment in the deployment of technology enabled, clinician supervised health coaches delivering enhanced primary care support to vulnerable patients. City Health Works locally hiring model gained national attention with features in Politico, PBS NewsHour, NPR, The Economist, Brookings, and many more. So I'm happy to introduce today Ms. Kaur, and we'll let you take it from here. Thank you.
Thank
Right,
you.
welcome.
Well, thank you for having me. This is a pleasure to be here. I recently moved to Indianapolis 2 years. Oh, is this on?
Yeah. Okay. Just to get you your own.
Great, thank you. Yeah, so it's a pleasure to be here. I love conversation, so I'm going to try to walk through this introduction and overview, and really looking forward to meeting you all and hearing what strikes your interest or curiosity. I'll start with just a quick overview. I'm going to introduce myself as well as the journey behind the company. I earlier started in the company that I've helped co-found now that's continuing on the same mission, and then introduce you to the solution and the associated results with City Healthworks, and then walk us through what Diverge Health is accomplishing. Is there an echo? I'm just a little bit. Yeah, it's fine. Should I keep going? Okay, cool. And then I'm going to walk through what the company I'm currently involved with is seeking to achieve, and how I'm what I'm focused on coming into this next year. So the learning objectives for this talk are around what were the key drivers of the health interventions that City Healthworks built, what we learned from the kind of key insights from the studies that were done around it, and what is the key challenge that Diverge Health has in managing patients and achieving financial and health impacts. So starting with the company overview, and I'll give more of an introduction to myself through this. As Joyce kindly introduced, I started City Healthworks in about 2013. I am from New York, born and raised, and recently relocated here to Indianapolis, which has been a real pleasure. And I'm kind of a non-traditional healthcare person. I'm not a clinician. I came into the industry with an interest in workforce development and a background in having spent some years abroad as well in low-income countries where the use of non-clinical workers in healthcare is very common. For context, in countries like Tanzania, there's 1 doctor to 28,000 people. And so the use of non-clinical workers, there's been a lot of innovation. I'm sure a lot of you are familiar with that work globally. And so after an earlier stage of my career, getting involved in these sort of initiatives, I came back to New York and started business school and used that time to incubate what became City Healthworks. And that was during the time of the Affordable Care Act. And so I was very interested in what was starting at that time. There was a lot of focus on readmissions, still are. And I was really curious to see if we could build a workforce that was an extension of primary care and filled a gap that is not easily met, maybe not even meant to be met in the doctor's office. And we ended up honing in on chronic condition, disease management as that gap for vulnerable patients. And I started the organization as a 501c3 because the goal was to build an evidence-based approach, test it out, and get researchers to look at the results. I had a lot of friends in business school who said, why are you starting a nonprofit? Don't you want to make money? Don't you want to scale something? And that was absolutely the goal, was to scale something, but I wanted to first see if it works. And so I'm not a researcher, but I've worked a lot with researchers along that journey to get external validation, as well as, done a lot of internal work to see, is it working? How do we refine the model? So City HealthWorks is an organization that ran from 2013 to 2019. By that point, we had already generated some significant results. We had served 5,000 patients across Upper Manhattan, upstate New York, and collaborated with key medical providers, academic medical centers, safety net systems, FQHCs, to really refine how we partner with the doctor's office. And then the pandemic hit. And at that point, we were beginning the process of converting to a for-profit and growing, to invest in growing our technology, growing our systems to support operating in other geographies. And that all froze because chronic condition management in New York City in March of 2020 was not top of mind for health systems. And so we made a dramatic pivot by identifying, we found about 100 of these small independent doctor's offices in New York City, and ended up acquiring a multi-specialty Medicaid, Medicare clinic in Washington Heights, a neighborhood in New York City that was serving about 12,000 patients a year, and worked on trying to convert a fee-for-service clinic into value-based care. So I really have a high degree of appreciation for what it means for healthcare providers who've been operating in fee-for-service to both keep the lights on and make payroll while trying to make attempts to move into value-based care, having spent the kind of COVID era doing that. We ended up winding things down and then selling the clinic. And at that point, I was soon after recruited to help start Diverge. So I'm going to now walk you through, what did City HealthWorks build? What was that solution? What was the approach to care? What were the results? And how are we translating that to our work here at Diverge Health, which is a venture-backed company supported by Google Ventures and a reputable healthcare fund that has acquired the methodology of of City HealthWorks, and is growing it right now in Michigan and Ohio, and soon in 2 other states. So I got the invitation to speak about community health workers and social care and the nexus of social and physical health. And I often chuckle when I get invitations because I'm really not a fan of the kind of more common way in which our country has begun to use community health workers. I have a perspective that's more grounded in a belief that I believe the healthcare system should first deliver on its core commitments to patients that they're expecting from healthcare. So I think most patients aren't walking into the doctor's office expecting the doctor to necessarily fix their housing, as much as that's a big driver, and it's certainly a major contributor. Our work has really focused more on just kind of the core basic fundamentals of primary care. And so what does that gap look like? What does the common experience of care look like for a lot of patients that we serve? These are the core population that we serve are vulnerable Medicaid, Medicare patients struggling with medical chronic conditions. Average number of medications that the patients we work with are on is 7, 8 medications. And on top of having personal barriers and social barriers, it's a lot of information and it's a lot of technical know-how to manage one medication, one condition. You add another one, you add 3, you add 4. And when you add on top of that, folks who have cognitive impairment, folks who have limited education, even if you have all those things in place, understanding the difference between a high and a low glucose read is not simple. And then knowing what to do about it is doubly not simple. And so our focus has been really driven around kind of elevating what is usual care by augmenting usual care with enhanced primary care, right? And doing so in a way that, in the context of a very fragmented healthcare system, drives more accountability in partnering with patients to kind of help make sure we're not letting the dots fall. I'm going to pause and share a video that was done a couple of years ago by the Urban Institute. We partnered with the Urban Institute a couple of years ago to do some qualitative research around City HealthWorks' impact on medication and impact on patient experience. And at the end of that, had an event where they captured kind of perspectives from industry as well as employees of our organization and patients. So with that.
The United States still spends more money per capita than any country on earth on healthcare. And yet we have health results that look like we're a developing country.
Health and well-being are not well in this country. Our life expectancy dropped for the second year in a row. 18% of our GDP is being devoted to healthcare. We need some pretty fundamental shifts in how we're approaching health and illness.
Today, almost half of all American adults have one or more preventable chronic diseases. These diseases include cardiovascular disease, high blood pressure, type 2 diabetes, and obesity.
Chronic illness is the dominant set of illnesses and conditions that are driving health care needs and healthcare expenditures. And it's not just the prevalence of these conditions, but it's how poorly we manage them.
Hospitals are really good at treating acute conditions, which unfortunately in this day and age are often acute exacerbations of chronic conditions. We do this great care when they're in the hospital, they get better, they leave, and then we sort of leave them to their own devices.
This is about high-touch, low-tech care. This is about patient care that is patient and caring. 85% of our national annual expenditures on healthcare, that's $2.7 trillion, goes to chronic care. Anything that can be done to control that figure and those dollars and redeploy them in other ways would be huge.
City HealthWorks essentially serves as a bridge between what happens in a doctor's office or a hospital setting and what happens when people go home. We do this by hiring people from the community and then training them to become health coaches.
Part of the work that the health coaches do is to understand what is truly affecting this person's ability to manage their own health. Addressing what those things are, providing education and empowerment so that the person can be successful.
I am from the community. I have lived there for 22 years.
My job as a health coach is to help people better understand how to make lifestyle changes without being judgmental, trying to see why they are not making the changes that they really want to do and what is stopping them. They get to understand this person really cares about me.
When you have a health coach really working as part of the team, they're hearing the counseling being provided, the education, the changes in medications, and then they're able to take that back into the patient's home setting. They're also acting as the patient's advocate, teaching that patient to be more vocal about their care, not to be afraid to ask questions or to say, well, what does that mean for me?
The most important thing I've learned from the health coach is to ask questions about my health. I have become empowered. My A1C is down to 6.1, and my asthma is more under control.
Of the first 200 people we served who had uncontrolled diabetes, on average, blood sugar reduction was 1.6.
From a cost perspective, the same group of patients, on average, there was a $600 per member per month drop in spending at week 10, and a $900 per member per month drop in spending by month 5.
Everyone is struggling with chronic illnesses. Diabetes is an epidemic. Hypertension is an epidemic. Having this robust community health worker workforce be able to address some of these issues, that could really scale.
We have an opportunity now in the United States with a major effort to realign payment with keeping people healthy in the first place.
Just take Medicare, 59 million beneficiaries, roughly. 30% of those folks have 5 or more chronic illnesses. $675 billion spend in 2016. And if you begin to change their health status just a little, you have huge cost savings and huge quality of life difference.
We really need to reach people where they are based on individualized care, and then being able to set up a community and an environment where they can be successful.
The center of this universe is the patient. And if the patient acquires the knowledge, and the patient has the motivation to change and to live a more healthy life, and the patient has the infrastructure provided to them, the doctor can remain the resource that they are for acute care activity and have the proactive, preventive, personalized public health activities performed by folks out in the community.
The demand for this is in neighborhoods across the country, rural, urban, suburban, and the availability of finding people who are super motivated to do this work is very high. The value of scaling it is not going to just be profound in terms of improving health outcomes and reducing costs, but creating jobs in communities that need them very badly.
There's no question that models like City Health Works can be very effective. Lower cost, a much more personalized way to bring care into a home. People have jobs in their neighborhood. They have trusted neighbors and friends that they're dealing with. And we are actually ending up as a country with people who live longer, more productive lives.
Excuse me. So that's just like a more authentic view on from different perspectives on what was the nature. When I say like we were focused more on the kind of the basics, I think you could hear that come through in the video. The more so the basics around, does a patient understand what that A1C means, how to take those medications, what to do when they're starting to feel thirsty and dizzy, what does that even mean? And so the whole premise was to start a approach to care where we identified patients. So I'm going to walk you through now the City Health Works prior organization in terms of who we were serving, what we delivered, what the results were, and then I'm going to bring you back to the present and what we're doing at Diverge. So with City Health Works, the intent was to partner with primary care practices and to give them the criteria of basically individuals with poor clinical control who were above the age of 18 living in the zip codes that we were targeting. And we also had ineligibility criteria. And this was based upon ensuring that the fit of our service was well matched with the population that we were serving. So we were not a solution or a workforce that was equipped to work with patients with end-stage illness, uncontrolled, a serious mental illness or substance abuse. And so what you see is essentially the kind of characteristics of the patients we serve were folks who on average cost about $24,000 a year at baseline. Average age was 64. About half of them were dual eligible on Medicaid and Medicare. The rest were either on Medicare or straight Medicaid. And a majority had more than one chronic condition. And so the components of our approach to reducing costs were partnering with providers, recognizing that physicians, nurse practitioners, doctors in a clinic are very focused on prescribing, diagnosing, but really don't have the time or the financial incentive to spend really ensuring that the patient understands fully what that care plan means. And on top of that, doing so in a way that is sensitive to the social circumstances that these populations are living in. And so our whole focus was moving people who are, if you go back to that triangle, kind of in that poorly controlled chronic condition category and moving them to become more controlled. At the patient level, the experience of our service entailed a home-based visit to first understand and assess what the patient's health goals and status looked like, followed by a in-the-home review of their medications, where our teams were composed of these health coaches who we hired and trained, who were under the supervision of a clinician, and the clinician on our team had access to the electronic medical records of all the partnering doctor's office. So when we would go from looking at the patient's goals and what they said, what they were struggling with, our nurse, our dietitian, our nurse disease educator clinician was looking in the EMR and seeing what were the doctor's notes, what were the labs, what were the problem lists, and putting that into our software so that on the follow-up visit, we would review the medications with that patient and see what's in the list on the doctor's office, but what's actually going on at home. What are they actually taking or not taking? What do they understand or confused about? What are they scared to say about the fears they have about why they're not taking that insulin injection, or very often just confusion around the different prescriptions. And so from there, we would move into one-on-one health educational coaching. So based on that patient's health condition, patient's goal, what the provider indicated in their notes, the focus would be on a health goal that was smart, realistic, and progress through weekly educational sessions at home, followed by monthly check-ins. So this lasted about 2 to 3 months, and then was followed by a monthly phone call as needed, kind of check-in. And along the way, we would escalate to the physician's, the provider's office, medical or medication issues that came up. And so what was kind of the infrastructure that we built to enable this entailed, I don't know what happened to the text, apologies, but entailed a evidence-based chronic condition coaching method, a workforce approach in building a workforce of non-clinicians supervised by clinicians, highly trained in disease education, and a approach to partnering with clinics that entailed bidirectional communication that resulted in quite a lot of engagement stickiness, which is not easy to do, given how busy practices are. And so just to kind of break down those 3 buckets, the coaching was centered on evidence-based guidelines. We modeled our approach around the American Association of Diabetes Educators approach to patient education that certified diabetes educators are typically taught, are not typically, are trained in, but adjusted it to a lay workforce. And our objective was, what does a patient need to know to be successful? And from there, we created a pretty robust training around training these educators. We started with diabetes. We then added asthma, hypertension, congestive heart failure, and COPD. And what you can see is that we built an approach that was holistic, that covered medication education, meals, monitoring, movement, and medical care. What's the importance of routine care, et cetera. A real cornerstone of what made our work unique is how we built a workforce that could do this, that was not clinically trained. So we hired from the community. These were individuals with minimum of high school education who were trained and assessed based upon a lot of role play based learning, had dedicated clinical supervision, a very rigorous approach to kind of report cards on their panel. So they were evaluated on a regular basis based upon the clinical outcomes of the patients they served, the patient feedback. We would do quality assurance calls, kind of standard performance feedback stuff, but I would call out that this is pretty unique in the industry to look at a layperson and see how are they delivering outcomes clinically for a panel of patients. And then behind that was a very robust upfront training and ongoing upskilling method. This is just an example of the type of knowledge recall that the workforce was expected to have. So in this training, they would take practicums to be able to demonstrate proficiency in understanding the disease knowledge, as well as how to apply it in educating a patient at home. The third piece behind this was our approach to working with clinics. And so the way this ended up looking is, a lot of you, I'm sure, have either collaborated with practices on research or, different, programs. Our approach was to make this as intuitive as possible and simple as possible, with the objective of getting lists of patients who had upcoming appointments, who had poor control, calling those patients, getting referrals of those patients, and then having our clinician supervisor be that bridge to the doctor's office. So I'm going to talk a bit more in the results section and around what did that clinic communication result in, what kind of insights and actions did it lead to. Before I go into the results, any questions around the approach to care that City HealthWorks built? Yeah. So it's a very live body of work at Diverge because we're now scaling this. So I can speak to both then and now. I would say challenges in recruiting are we have a very low bar of background requirement, so no formal education in healthcare. No necessarily, I actually preferred folks who didn't have healthcare experience because if you've worked as an EMT, or if you've worked as a medical assistant, or if you worked as a home health aide, you're used to being trained to do something for a patient. We're doing the exact opposite in our approach. Our whole approach is teaching a patient how to become independent and self-management. It is very hard to retrain the instinct of a nurse, someone who's been doing their whole work and life appropriately, doing for a patient. So we really did a lot around figuring out the right profile, but I would say there's not like a fixed, perfect persona. There's a pretty broad type of set of backgrounds that would fit, but what our work is really around finding individuals with minimal formal experience who have incredible raw talent and an ability to learn pretty complex knowledge. I mean, there's no shame in folks who start going to our training and can't do it. It's actually just like it's a lot to be able to know the differences between the different drug classes of diabetes. It's a lot to know the differences between a rescue and a control inhaler. But if for our work to succeed, we have to make sure that we're training them in a way that it is accurate, because if we're giving inaccurate information, that's a patient safety risk, and fidelity to success. So in terms of recruiting, we find a lot of candidates who are interested, especially because we're hiring in the neighborhood. It's serving your own community. It's a free training. It's a lot of draws to get people in the door. And then we work with psychologists to develop methods to kind of screen out as much as possible folks who have a orientation to motivational interviewing. So we're looking for folks who are not trained in that, but who have a naturally strong active listening ability and non-directive orientation, coupled with the ability to show that they can learn quickly. So we put a lot of tests in the hiring process. So teach back, we'll do a sticker shocker, have them watch it in the interview process, and then say, now show us how to do it. We'll do a MyPlate demonstration in the interview process and say, these are the three main, points of knowledge about the MyPlate. If you were teaching a patient, now teach it back to me. So we try as much as possible to kind of filter down people who have that sweet spot of learnability, non-directive orientation. And then the training is very applied. It is almost like a preceptor-based model of a bit of, kind of minimal lecture, heavy on role play-based learning, and then applied feedback where we're shadowing the initial and even ongoing, we're shadowing to see their ability to apply the skills, and then continuous learning. So it's a hugely important investment, and it's not easy work, I guess. It's kind of not like a magic bullet to it, but those are key drivers. So I'm going to drill down into different pieces of this, but this is kind of a snapshot across the 5 chronic conditions that we served of the results on health outcomes and cost. So starting on the top left, for diabetes, on average, the baseline A1C was hovered around 9.9, 10. So these are folks who have poor control. On average, 80% of patients across these conditions had some improvement in health outcome. And on average, about 45% were able to reach control. So depending on your clinical condition, control for diabetes is A1C below 8, and so forth for different conditions. We partnered with the most rigorous assessment of impact was a RCT on asthma done by Mount Sinai researchers, funded by Kakori, that found that for our asthma patients, that was a intervention of about 2 months of a weekly coaching program, followed by monthly phone call, resulted in 50% fewer ED visits at 12 months in relation to controls. That work was then funded by the NIH to do a COPD trial, which got disrupted by COVID and is now underway. So taking the same model and approach, the researchers are studying the effect on COPD using the same methods that we created for asthma. Congestive heart failure was the most acute condition we served, and it was something we delivered uniquely in a hospital setting. Everything else that you see here are results based upon working with patients referred or identified through primary care. With congestive heart failure, we were retained by a hospital to meet patients at the bedside and then work with them post-discharge. That study also got disrupted by COVID, but we were giving programmatic data that showed that the patients we were serving on average were coming into the hospital like once a month. These were frequent admitters, and it became a non-event. So even though we don't have data, we have programmatic kind of data that shows that it was a really rare event after coaching. And then the diabetes and hypertension were really like the bread and butter of the volume of the patients we served. That about 70% of patients we served had a primary condition of either diabetes or hypertension. For that one, we have a recently completed propensity match score trial that was, or now a trial, but analysis that was conducted by NYU's Population Health Group using the New York State Medicaid database. And I'm going to give some highlights on each of these studies now, given this audience is obviously probably interested. Yeah, and I'll also just point out on the programmatic side, when we would make phone calls to patients to enroll them, our enrollment rate was about 50%. And when a provider made it a referral, our enrollment rate was about 60 to 70%. And I think that speaks a lot to the way we partnered with practices, but also we saw a lot of word of mouth in the community. So on that NYU study for diabetes and hypertension, it's actually going through a review process right now. Also very delayed with the pandemic, but it's finally kind of moving along to be moving to publication. But it's such an important one for us because this one looked at total cost of care limited to Medicaid database and Medicaid costs. But it looked at the baseline spend, which was $24,000 for this population. These were patients identified by the safety net health system in Harlem who were, same eligibility requirements. And based upon the match control developed by the researchers, the impact was a $14,863 avoidance of spend in relation to the control group at 12 months. I'm not going to walk through this one. This is just more of a snapshot of the clinical impact, a poster that we submitted a couple years ago. This is on the left, the asthma RCT in JAMA that I referred to, and just like the feasibility analysis on the COPD one that's underway. But what I think is maybe to help make the numbers come alive a little bit more, we measured something called escalations, which was the number of times and the nature of situations in which we were identifying a medical or medication issue or social issue that was beyond the scope of our care team. So beyond the scope of our clinical supervisor and health coaches. And what you see here is the average breakdown of what those situations were related to. And so this actually surprised me. I didn't expect it to be looking like this. I expected it to be more that we were identifying like potential wounds or symptoms that were going to become a problem. But 40% of the escalations that we brought to the attention of the practices or the providers were medication related. 20% were testing and medical supply related. And then about 15% social worker related, 12% related to actual like symptoms, wounds, or sugar levels, like your, based on monitoring data, like someone's sugar levels or blood pressure being very dangerously out of control, or behavioral health was about 5%. And as you saw that video, we worked with the Urban Institute a couple of years ago who dug into the more qualitative side of our work. This is a snapshot of a research brief that you can find where they looked at that 42% of those cases that were medication related. What were the drivers? What were the common themes? And what they identified with the two big buckets that were driving these situations where our care teams were identifying escalations were around discrepancies and complications. So discrepancies were like examples of that were medications prescribed that were different than the ones that were at home. Prescriptions from different providers that didn't, weren't in sync. Having multiple pharmacies that patients were using. And very often miscommunication between the prescriber, the pharmacy, and the patient. Examples of complications are situations where we identified things like expired medications, not unexpected in a low-income community, right? You don't want to let go of those. Non-prescription medications being used that weren't disclosed. A lot of patient misconceptions, which I think is incredibly reasonable, right? An example would be a spouse who was taking, filling their prescription for insulin, but not taking it because when their husband passed away, he passed away soon after starting insulin. And this woman was scared that if she started insulin, that was going to be her fate, but didn't want to tell the doctor. Often with immigrant communities, you'll find folks like that who want to do the right thing, but are scared to actually say why they're nervous. So, and then of course, complications because of the social factors, low literacy levels, poor eyesight, food insecurity, big one. And so the second research brief that the Urban Institute did was they interviewed a random sample of patients. And there are a number of themes, two big themes I would highlight from the patient perspective on having this service where, and I think one call I would particularly point out is just the number of times that we saw that this was the first time anyone ever really understood what the disease means, what to do about the diet. I think the most people had the experience of being given advice, but not knowing what to do with that advice. Okay, less salt for your hypertension, but like realistically, how do you do that within the constraints that you're living with, and do so in a way that makes you feel good about living, you're not miserable about it. So that's an overview of the results from City HealthWorks. Again, that organization we started in Harlem, operated in Harlem and Albany, ended in 2019. I'm not going to talk about too much about the work I did during the pandemic because it's not as directly relevant, but I'm going to jump to Diverge Health, which is sort of picking up where we left off in 2020. So Diverge Health was formed 2 years ago. It was formed in partnership with a fund called Triple Aim Partners that focuses on care delivery businesses that are targeting Medicaid, Medicare patients. And so Diverge specifically is largely focused on Medicaid and DSNP populations. Where our services are concentrated is that we're particularly focused on primary care practices that are independent and that have a majority panel of patients who are on Medicaid. There's only a few states in which we still have a significant enough number of independent practices, but they still exist, right? We see in the news so much around over the past number of years, acquisitions of these small practices by big systems. And so Diverge is focused on working in states where there still are, a sizable proportion of these practices who, notably for practices that say yes to taking Medicaid end up having the majority of the patients be Medicaid and DSNP. And so our focus is working with these practices to help them move from fee-for-service into value-based care. And so what are the pieces that you need to have in place? So this is not an exhaustive list, but I would highlight 5 really majorly important just ingredients for a fee-for-service clinic to be able to make that transition. One is proactive care, right? Moving and managing patients not episodically at the point of visit, but when they're sick, but following them through over time. And then data, and then the financial agreements with health plans to incentivize the provider to be working not just on a fee-for-service basis, but improving the outcomes. And so our approach at Diverge is essentially to bring those pieces together, We apply the care model that City HealthWorks built. We also apply other services. I'm going to go through this a little bit more quickly because I want to make sure we have time for questions. Let me skip over this. So we're working with practices that are independent, as I just described, who stay in business as usual, basically. And what we do is basically wrap around them with the full risk contracts and the care of our care teams in these markets, which entails that chronic condition coaching, behavioral health, as well as other administrative services. And so, what is our approach is that for those who are not familiar, taking full risk on a population as a value-based care provider means that we are working with insurance companies. I skipped that slide, but we're working with most of the major Medicaid health plans now. We're operational in Michigan and Ohio and starting soon on the East Coast. We're basically taking thousands of lives from a health plan and then partnering with doctors' offices to take the responsibility of making sure that those lower risk patients, the less sick patients, the ones who are somewhat stable, making sure that they're going in for routine care, and then proactively identifying those patients who are rising risk, who are higher need, and moving them through one or more of our services to help them stabilize those needs and return to kind of routine care. And so kind of maybe transitioning to what I'm focused on now, what I'm focused on going forward, what I would love to be in dialogue with some of you around is, I would say Diverge Health's challenge is getting the right dosing of support for the thousands of patients that we're responsible for. So our goal is to reduce the cost of care, allocate the right amount of support for the right populations, and let me just move past this. And do so in a way that doesn't burden the practices that we're working with, allows them to stay, maintain some stability of running their practices, but brings those services in a way that is meaningful, measurable. And so we see success as both impact on health outcomes, which then drives reduction in avoidable hospital visits, avoidable ED visits that reduces cost, as well as we see success as being driven by having more and more of our physician practices making those referrals, which is a testament to them seeing it works. So I'm gonna kind of close by saying where I'm kind of focused now is spent the last 2 years with our team standing up and building out this new organization. We're now growing and doing the hard work of getting those things working, right? The recruitment, the training, the technology in different environments. And I'm starting to put more attention with my team to say, how do we look at impact in a way that's kind of stage appropriate, that's practical? We're not a research organization. We're not going to, our success isn't based upon getting things published, but our success is based upon saying, all right, if United Healthcare in Michigan is giving us 20,000 lives to manage next year, how do we know that we are spending the right amount on those services, saving enough money on reducing the cost of care, as well as improving shared savings through quality, that both justifies the spend that we're putting in, as well as results in a good outcome for the patient and us financially. And so a big part of that is setting up practical ways of measuring care effectiveness early and often. And so that's going to be kind of a core focus going into the new year. So I'll stop there for questions.
Thank you for your talk and welcome to Indiana.
Thank you.
So I was interested, I mean, value, very simply, of course, is a quality cost ratio. And so in mentioning, cost is always the easiest thing to measure. So I'm interested how you're going about measuring quality. I saw those evaluations, and so those were positive movements related to patient outcomes. And so is that a way to justify the program, or are there further incentives that you're responding to, that you're negotiating into your contracts, or there's a lot of criticism about there being too many quality measures in primary care. So it's a lot to bite off, but how do you conceptualize and then eventually operationalize quality in your program?
And when you say quality, you're referring both to the quality measures, but also quality of the care?
You
Or
can
both.
take a liberty, patient experience
Yeah.
process.
Yeah. I can tell you how I think about it. First, I'll answer with how a lot of the value-based companies in our space think about it, and then I'll answer how I think about it. Much of the progress over the past 10 or 15 years of the for-profit companies that are taking on that risk, partnering with health plans in the way that we are, have looked at it, has largely been through looking at the impact on the shared savings, which is driven by cost of care, as well as those check the box, making sure patients are coming in for the cervical exams, annual wellness visits, and those drive dollars. Diverge is incorporating that, but is spending more than the typical, like the traditional value-based care business. We're spending a lot of human capital in these markets, and has taken a leap of faith based upon the results of City HealthWorks, based upon some other studies as well. But at the end of the day, it has to deliver on that in a live way. And so the way I think about it is absolutely still building on the kind of basics around total cost of care, as well as those quality dollars. But I know from my experience working with the results of the past that how you look at the data is really important. So for example, cost of care on that NYU study, it wasn't observed on purely like a pre-post basis. It was observed on in relation to controls. And the same thing with the asthma RCT. So, right, what and why is that? If you think about it practically, if we're working with people who are recently been seen in the last 3 months and have a high clinical indicator or poorly controlled clinical indicator, right? Folks with chronic conditions are living their whole life with this, and they're going to have ups and downs. And if we're getting them when they're going up in risk and bringing that down, what does that look like in relation to folks who are not getting it is so vital. So figuring out practical ways without going overboard is really essential to create those comparisons. And we have the advantage that City HealthWorks definitely didn't have, which is we're in full risk arrangements with the health plans, and we get a monthly report every month with all the claims data. So we have access to a ton of data. The other way I see it is some of the like leading indicators to me are we sending these escalations? Are we identifying these escalations? Are we sending them to the doctors? Are we getting responses from the doctors? That's a key indicator. It's a very strong leading indicator. A second one is that we're looking at the clinical outcomes every quarter. So health A1C, blood pressure, are those trending down? The other, so it's kind of like health leading indicators like that. And we're in the process right now of looking at like the kind of menu of things we could look at and be as simple as possible, so that as a large business, we, with a growing staff, that it's easy enough that everyone's aware of it, everyone's kind of like driving towards those goals, and it's simple enough. So that's, but I'll just round it out by saying like a lot of the industry is mostly though focused on the list of HEDIS measures, and doing so in a way that's very broad based, these call campaigns, text messages, have you seen your doctor this year? Whereas we go a lot deeper. We also do the broad based stuff, making sure patients are coming in, but with more resource.
We have a question from the online community. It's from Rachel Patzer. Really great work and really high impact. I am curious how you engaged with researchers to get involved with this work to test the evidence base, and what you might recommend to us as researchers to partner or get engaged with companies like yours that are connecting clinical and social care needs.
So in the first iteration of my career with City HealthWorks, I was a startup entrepreneur who wanted to create something in healthcare, and I knew I needed evidence. So I just knocked on a lot of doors and said, will you talk to me? Will you help me? Will you do research with us? And so, and we leveraged, we raised philanthropic capital and partnered with healthcare systems and said, listen, we've got funding from Robert Wood Johnson and Robin Hood and some good partners. We're asking you to give us access to your EMRs. And do you have researchers who are willing to kind of work with us to both make sure that we're setting this up well? So both intervention design, we collaborated with the researchers on with that. Well, let me put it a different way. Our clinical leader herself was a dietitian with an MPH who was at that time doing her PhD in health service research. Didn't end up finishing, but it was we were both building something with that end in mind, and then finding external researchers so that we had credible evidence. I will say that coming out of that stage of my life as an entrepreneur, starting something from scratch, it was incredibly difficult to find those relationships. And I had no leverage over any of those researchers to say, get it done on time, right? So the ones that were funded by, PCORI or NIH, like happened on a timeline that was predictable, planned. The ones that were not, like kind of system funded, took years to say, please don't forget us. My advice for work, and then the Urban Institute came up organically. Someone reached out to me and said they had started, I was the inaugural Janice Natelli Fellow. They started a new program for this actual reason that the Urban Institute wanted its researchers to be more in touch with practitioners. So it was a phenomenal experience to work with these researchers, I think for them and for our team, to have that external body coming in, not just looking at the numbers, but like, how do we think about like leading insights? Like, what are the qualitative factors we should know to look at? And so I guess my advice is, to have conversations like this. I appreciate the invitation. I want to kind of advance my own thinking about it, because I'll say, be really direct that a lot of the business world and my colleagues on the business side have a deep mistrust of like academics and the distraction. And I get where that comes from, but I also think it's a perception that's not necessarily well founded. But I also think that researchers, it's important to ground it into what does a company need in the near term and the long term, right? Like an RCT can take a long time, and there could be really strong business case for certain organizations to do it. But knowing how to, provide different approaches, I think is important, and being, I think the industry, though, from the industry side, I'll say like they can learn from partnering with researchers early on designing the services, right? For you as researchers to do a good job, right? The earlier you're involved in design of intervention, the more likely both are set up for success.
Thanks for this talk, Chris Harley. I have many questions. This is fascinating stuff. I think I'm most fascinated by those conversations that your team's having with one doc shops, primarily Medicaid serving, and sort of generating their business. I mean, those are hard practices, I think, to operate and run. And so I'm just really interested in that value proposition that you sell to them and seem to have been successful, at least so far, in bringing them along. And what is it that they really buy into?
So I'll say with City HealthWorks, we were mostly working with practices at systems, FQHCs, system. Diverge is doing something really interesting, which is working with independents primarily. It's not to say that we won't work with systems potentially down the road, but these independent doctors are interesting. And during COVID, acquired one and ran one for 3 years. So I have a different also perspective on how, I guess an insider perspective, they're very differently run. The psychology is really different than, right? You're essentially like a small entrepreneur because you're running your own billing, you're getting your patients, you're doing the whole thing. These practices are, I've been struck by actually how quickly we've been able to get so many of them signed up. I think that they are so removed from industry dialogue and what is value-based care, but not unaware that the industry is changing. So I think there's an attraction to be able to be part of a network where they're able to kind of participate in the future, where healthcare is going. There's financial incentives. So we split 50-50, the financial gain of shared savings with them. So I should have mentioned that. I kind of rushed through a little bit. So there's certainly a financial incentive. which is a big deal for Medicaid practices that are seeing like 30, 40 patients a day with very low reimbursement. So those are like two big drivers. I'd say the third driver for us and why we like to work with them also is that they are quick to work with, right? If you're trying to do a partnership with a big system, it can take a long time.
Is part of the pitch being able to work at the top of their license?
Absolutely.
Yeah.
That's the goal, yeah. And at every level, right? Our clinical supervisor layer as well.
Hi, my name is Rosalind. Thank you so much for this incredible talk and the incredible work that you're doing. It's very impressive. I had a question with regard to the health coaches and community health workers and how much of their work ends up bleeding into the realm of social work. I know that it seems like they are incredibly valuable as educators, but if they are encountering, for example, issues related to, for example, transportation or domestic violence in the home, what kind of resources are the health coaches, are they able to provide, or do they have referrals to other community organizations, domestic violence organizations or other like transportation organizations that they can help with? And basically, how does that fit into the role of a community educator?
Yeah, I'm glad you asked the question because I wasn't as explicit about it. So going back to the task shifting top of your license, and not in a pretty similar way, they're not social workers, they're not trained social workers, but they are incredibly effective at building rapport and trust and getting patients to, often not in the first visit, which is why we actually like wait to even assess for and ask these questions around social determinants, because they're very personal, whether it's food related, income related, domestic violence related. I mean, these are so personal. So we're really like thoughtful about not asking those up front. And what happens typically is that those factors come out very richly, very honestly, right? And so our role is to both open patients up to feel more comfortable articulating what they're struggling with, also being skillful in identifying some of those. We train them on what are asthma triggers in the home. So like, is there mold? What are the common things you're going to see in households that are low income? So we were kind of trained to be detectors of what's going on in the house, both like triggers, falls risks, who's in the home, who's cooking the meals, where are the meals getting bought, who's buying the meals, kind of probe respectfully to figure those things out. And one of the biggest areas we focus on the social referral side is food insecurity. It's very addressable often in communities that have some services that you can kind of unlock. So we see ourselves as both helping teach the patient not teach them, first feel comfortable with that reality so that we can help them figure out what they want to achieve, where we can help support, enable, refer, and then we're following up. Kind of going back to the earlier comment, like part of what drives me is that it's so frustrating as a human being in this country to not have that follow through. So we take pride in saying, all right, we didn't just make a referral, what happened next week? What's happened the next week, right? So following up on that and being part of the journey.
We have one more question from online. This is from Melissa Thomas. Sorry if I missed this in the talk. I was wondering if you could speak towards the funding of the CHW positions. It sounds like a mix of MCO contracts, value-based payments, and grants. Have your health systems been able to engage with reimbursement rates for CHWs? Or how were your programs able to develop a suitable, sustainable funding mechanism?
So there's the community health worker role that has grown tremendously in this country, which is largely doing the job function of closing gaps in care, calling patients, care coordination, social determinants. What City HealthWorks built in its chronic condition coaching model is a different scope of work. It is building upon this concept and kind of taking to the next level, using a person like that. And so what City HealthWorks was using to fund it was a combination of grants and research dollars and subcontracts from health systems as a nonprofit, right? That kind of, the intent there was to prove it works and get that type of money that just first show that it works. Diverge Health is not, so my current company is not funded through grants or MCO subcontracts or health systems. We're funded through getting full risk contracts with the health plan. So if there's $100 to spend that United Healthcare is getting for that Medicaid patient each month, we're getting like majority of that dollar. And then we're responsible for how that dollar is being spent across the dental bills, the ambulance bills, the hospital bills. So we've essentially become like the insurance company, and we are taking that responsibility. So we're not justifying to anyone externally. We're actually justifying to ourselves to make sure that how we're spending the dollars is going to result in enough savings because we're taking that risk. Does that answer that question? And I guess in terms of the industry, I know there's a lot of dialogue in the industry about payments and reimbursements, but we're not taking that approach. Just our workforce is different and our business model is different.
So we, on behalf of the Regenstrief Institute, want to thank you for spending time with us and for everyone for engaging in this wonderful dialogue. Thank you.
Thank you, and it was a pleasure.